Assalamu alaikum, everyone. Am I audible?
Yes.
Right. So I've actually not said before that we're having a session, but I was just wondering, there are a few things that I've been taking mocks and I repeatedly see that a lot of people, because of the amount of scripts they've read, a lot of them are just on this one line and they keep reading all of the same lines without using their own brains, without using logic, without using logical reasoning for a case. I've still not received anyone's stem for euthanasia, so I can read it up what it's actually coming like and what are the questions or the concerns. But I do know about the child who's unable to walk, who's 14 months old, and the baby is unable to walk, and the parent, mother or father, is very concerned. And the most important concern they have is that will our child ever be able to walk? Or is this permanent? And now these are very intensive questions. Those of you who are parents would know that these are these questions have a lot of density to them. So you can't just say, oh, I'm reassuring you, it's normal, because you've read it in script somewhere that it's normal. It's not for sure normal. And the reason I'm saying that is because as a junior doctor, you're expected to rule out the differentials. Like you have no other choice but to go ahead with one particular diagnosis. That's what is expected of you. So if you only go ahead with one diagnosis and you don't do anything else, you will fail. If you go ahead with all the differentials, but you've not really confirmed your diagnosis with a few questions, you will still fail because that is where you're scripted. An example of that is a very common thing that I see is whenever I'm doing chest pain with someone, the first question they ask me is, can you tell me a bit more about the pain? I say, well, it's been for this amount of time, or it's in the center of my chest, something along the lines. The next question is it going to your left arm and jaw? So why is the next question, is it going to your left arm and jaw? Elaborate the pain. Why are you already categorizing it into MI or angina? Elaborate the pain first, then do the differentials question, then confirm your diagnosis with 2 or 3 more questions, and then move ahead. Anyway, having said that, keeping that aside, now the not walking child's case is very easy, to be honest. There's nothing much in it, but the reason a lot of people fail it and the reason a lot of people are not able to get through it is because they're too scripted with the fact that the only questions they ask is about development, if the child has attained developmental milestones. The second question they ask, any delay in family? Did you or his mother or his father walk late? Which again is a very, very stupid thing to ask, because this is a myth. This is not true that if parents have a delay, so the child will have delay. No, your motor skills are not genetic that you get them. They are just there. Anyway, the next thing that they ask is the most interesting thing to me is the autism check that they do, by any chance, does your child smile back? Does he make eye contact? Is he particular with his set of toys? Now, why will you do a behavior check in someone who has a physical problem? I don't understand. Most of them will go towards an autistic check, which is because a child not talking and a child not walking should be similar, but that's not the reality. The reality is a child not walking can have behavior problems. He might be selectively mute. He might be permanently mute. He might have some other problems. I'm not getting into details of that, but a child not walking is literally any physical issues, any problems with the bone, with the muscle. So you have to use your brain, to be honest. Don't use the scripts. Don't use any of these things. Just use your own brain, right? So now what I usually tell people, a worried parent is there, my child is not walking, will it be permanent? I understand your concerns, and rightly so. It's justified the way you're feeling, but I am here to make sure things are fine, and if they're not, so they're given attention at the right time. So I'll ask you a set of questions to see how your child is growing, because I have to see and observe your child through your eyes and through your perception of him, right? After having said that, you have to ask the questions from the mother. Now, what are the questions? Has it happened that he tried to stand and he fell, which is why he's scared of walking. Is your house baby proof? Why are you asking baby proof? Baby proof houses have really thick carpets and they have barriers for stairs and they have switches off. So you already know that the child is in a safe environment. So even if he falls, the fact that he has fallen and he's not walking, that goes to a side. Are you by any chance making him wear shoes or making her wear shoes, which is why they're unable to walk? Very important. Again, maybe the shoes are too tight or the child doesn't know what to do when the shoes are on. Maybe the child thinks that when the shoes are on, I'm not supposed to walk, I'm supposed to sit. So this is another differential. I always say trauma should be your first differential. So trauma, we've ruled out if there are any tight shoes. Now let's go towards bigger causes. Now, have you ever noticed any abnormality in his legs? Have you noticed that the two legs are not the same? Have you noticed any abnormalities at the back of his leg, calf muscles I'm talking about, because Duchenne muscular dystrophy comes with that. It's difficult for those patients to stand and they have a walking delay. You cannot rule it out without asking. You cannot rule it out without asking. Again, hip dysplasia, outward rotated hip, very common. You've seen this in PLAB 1, these questions come. But if you don't ask, you will never know. So you have to ask the mother that by any chance, have you noticed any deformity? Do you feel like his hip is deformed? Do you feel like one of his legs is shorter than the other? Do you feel like one of his leg is bigger than the other? Because you're looking at atrophies and hypertrophies as well. Do you notice any abnormalities at the back of his legs? Do you notice any color abnormalities? Don't think that these are unnecessary questions because the examiner expects you to have differentials. And believe me, the last thing he wants you to check on is autism, really. In a 14-month-old child, it's very hard that they even say anything, and it's very hard to do an autism assessment as well on them. So don't go towards the autistic questions. Do these questions. Now, apart from that, what's the other question? Any problem that you've noticed in his soles, any problem in his heels, any problem in his toes? So you're literally exploring everything. Is there any skin lesion on his feet or anything that might be painful that he's not walking? You're exploring all of the things. And nobody has taught me these. I am thinking of these questions because I'm thinking logically that if someone comes to my drawing room and they're a relative of my parent, and I have to be really nice in my mannerism to them, but also I can't just, put it under the carpet and ask them to go. So I have to be very serious and I have to literally take responsibility for this child or this person when I'm talking to them. So I'll be very sensible. And that's what you will do in your outpatient departments as well. Logically, you will ask the mother the reason why the child is not walking. If the child is not there, you will do all of these questions. Am I making sense so far?
Yes, doctor.
Thank you for that. Now, having said that, then you have to do the past medical history, any previous history of broken bones that he might have, any history that he might have issues with fractures, any recurrent admissions to the hospital, any family history of any bone disorder that runs in the family, because we need to be aware of that. So you're actually exploring all of that, and then do the psychosocial. Now, don't do the psychosocial of the child, do the psychosocial of the mother. So because you're really worried, I think vitamin D should be the last on the list because that's the rarest thing a problem will develop. Look at the common causes. Commonest things in a child will be developmental delay. And I'm glad you brought it up. Now, coming to developmental delay, you don't have to check all the milestones until where he grasps something or he's able to hold his head, she's able to hold his head. Why? Because developmental milestones are called milestones because you can't achieve the next without achieving the first one. So you only cross-check the backwards one. You ask the parent that, is your child able to stand? With support, without support, is he able to stand? Like he's not walking, so is he able to stand? Is he able to stand with support? So if he's not able to stand with support, does he crawl? And when he's crawling, is it normal? Is he using both the legs or no? So now if the child is crawling, that's it, the legs are fine. However, you will still have to do your differentials and other questions. Those are mandatory. As a junior doctor, you have to do differentials. You can't leave them there, right? After that, what's next now? The psychosocial of the mother, of course, you've been giving it a thought. What do you think is going on with your child? Why are you so worried, and how have you been taking this news? Have you discussed it with your partner? So these are different sort of questions that you can increase your interpersonal skills or try to have insight into the mother's psychosocial state, to be honest, find out what's going on her end. And also you have to check if she's encouraging the child to walk. Does she spend more time with the child? Because if she spends more time, she will be encouraging more, and if she's encouraging more, there's the likelihood that the child will walk. But if she's not engaging with the child, she's busy in her work, and she's only worried he's not walking, so there's no input from the mother. So you have to do all of these things. Then comes the management section, and only after you've ruled out all of those things, then you can talk to her that from the questions that I've asked you, I don't see any deformity, neither do you. I don't think there's any abnormality with the toes and the feet. So it's likely that this is just developmental. So we don't need to worry about anything at all here. Your child will very soon start walking, and different children have their own pace. So you can then talk to her about all those things. I can tell you for now, as of now, of my assessment, it appears that this is just temporary. He will be fine. However, it'll be amazing if you bring him in and my senior can see him and we can be sure things are fine with him. So that would be really, really important, because examinations are important. So you can verbalize that. And if you have examination findings, well, then you're good to go. You can reassure her completely that this is just temporary. Don't worry about it. Your child is fine. He's moving his legs. And I know parents can become impatient sometimes because they really want to see their child achieve that next step that they've been waiting for, but it's normal. And just reassure her then. But you can only reassure after you have done all of this assessment. And if you fail to do this assessment, it's as good as nothing if you haven't done. And you can't reassure someone without cross-checking with a lot of things, without confirming that this is not actually any other problem, and it's just a development stage where the child is going to develop eventually. Just because the script says that it's normal doesn't mean it is normal. Remember that. Okay. Now, the next case does anyone have any questions so far in this case?
Dr. Aisha, when we will ask about the milestone, we have to go in backward direction. Yeah. Not from when they have started holding their neck, when they started sitting, when they starting crawling, when they starting standing. It's mean you have to go, does your child stand up without sport or with sport? If does not, then you will ask about crawling, yeah, and then go backward. Okay.
Backwards. If he sits, then you're trying to find out which was the milestone where the child stopped developing further. You see what I'm saying? Because that is where the child actually stopped developing, and you need to pay attention to, because milestones are different parts of the brain developing over the time the child is developing, right? So when different parts of the brain are developing, you're trying to locate what was that stage where his brain stopped developing further, where his gross motor skills stopped developing. So you have to go in the backward direction, because this child is pretty much on the walking state. A mother whose child cannot sit will never come and say, my child is not walking, because she'll be worried he's not even getting out of bed, which is most of our mothers get out of the bed. So anyway, that's what I was trying to get across. Right.
Thank you.
Any other questions? You're welcome.
Dr. Aisha.
Hello, Dr. Aisha.
Sorry. Yeah.
Hello.
Hi.
Actually, my question was, can you just briefly tell about talking also, like what differentials we can rule out?
No,
there's one more case.
Very long case. Talking is a very long case. And I have, because talking is mostly connected to, I would say, psychoanalysis of the child, behavior analysis of the child that you're doing in that case. So it's a very extensive case, but however, the differentials are autism, but not only autism. The differential is deafness. The differential is developmental delay. The differential is also the fact that the child might have a tongue tie. The differential is the child might have sore ulcers in the mouth. Maybe the child has recurrent tonsillitis, a very common condition, which is why it's just he's in so much pain that he isn't talking. That is one of the things. So you have to keep these differentials. You have to ask about these things in that case.
Okay. Thank you so much.
You're welcome.
Dr. Aisha, yes, how about the follow-up in this case? We need to tell the patient about the follow-up.
Yep. If he doesn't walk by the age of 18 months.
18 months, yeah. Okay. Thank you.
You're welcome. Right, so if we're done with this case and we move to the next one, I'm not summarizing anything. I'll upload this on my YouTube so you guys can hear. Those who have a difficult time staying here, they can go if they want to. So euthanasia. Mother has been diagnosed with cancer, is on palliative care. Son lives in Switzerland and wants to talk to the doctor. I want the suffering of my mother to end, so give her an injection to reduce the suffering. Can I take my mother to Switzerland? Very interesting questions, both of them. But I want to know, is the mother conscious or she's unconscious if she's on palliative care? Is like she's stroke, she's a vegetable, what is she? Can someone tell me that? Because it really makes a difference if she's a conscious or awake patient or she's asleep. Okay, the mother is unconscious. Now let's go to euthanasia. And makes it more challenging if the mother is unconscious. I'm just reading up on it, just a minute. So I'll share it with everyone as well. I'm reading it up on the NHS website. That's my go-to place for everything. And that's what should be a go-to place for everyone, to be honest. Right. So if you can see the screen, we have euthanasia here. And euthanasia is voluntary, involuntary euthanasia, but all types of euthanasia is unlawful and illegal under English law. Assisted suicide is illegal under the terms of Suicide Act and is punishable for up to 14 years imprisonment. Trying to kill yourself, however, is not a criminal act. Euthanasia is regarded as either manslaughter or murder. The maximum penalty is life imprisonment. End of life care. When you're approaching the last stages of your life, you have a right to a high quality personalized end of life care that helps you live as well as possible until you die, right? So you see this end of life care definition here is a very nice one, that we'd not go with euthanasia because the care that we're offering your mother is a personalized end of life care that will help her live as well as possible until she passes away through natural reasons. Now, again, euthanasia case is complicated. What you need to ask the son is that, did the mother leave any advance directives? Did she want to live any place? As in particular, she wanted to live in a place. How has he been taking the news? How has the news been taken by the family? A lot of, I'm really sorry that you're going through a lot. This must have been a very difficult phase for you and your family, especially to see your mother on palliative care and being unconscious for all this time. Now, when you're talking to him, you need to ask, how long has the mother been on palliative care? How was she before this? Did the doctors discuss palliative care with her? Did the doctors discuss the palliative care with him? Any advance directives? Is he the next of kin? Is he responsible for her care? And all of these things are very important. Now, remember, in an unconscious patient, there is no suffering that they are going through because they're unconscious, so they don't feel anything. That's the first thing. So you have to tell the son that I understand if he gives you the concern that the first concern, I want the suffering of my mom to end, so give her an injection to reduce the suffering. The first thing is, Mr. XYZ, your mother, you see it as suffering, but to be honest, I've seen a lot of patients in palliative care, and the amount of care, the amount of personalized care they're provided with makes sure that they are not suffering at all. So your mother is not in pain at the moment. She is not neglected by the system. She's getting her nutrition checked and her hygiene assessed by us. And we're doing all that we can to support her, to have her dignity, to have her respect, right? So he will say that, but end her life with an injection. But the first thing is that it's unlawful under the law of UK to.
That's all very easy. Now you said Yatiman Rama Krabatin 10 times.
Right. Where was I have such intense ADHD, I forget where I was. So I was telling you that you need to tell her that she's not suffering. We're making sure that she has personalized care. We're supporting her through it. So your mother is not going through any pain, and it's unlawful under the law of UK to kill someone. This is literally killing someone against their will, and your mother is unconscious. So we don't even know what would she have preferred. And mostly people prefer a dignified natural death. They don't want to go through euthanasia, and it's subjective to people. We can't force, we can't do anything, and it's unlawful as well. So he says, can I take my mom to Switzerland for it? You can tell him that while your mother is here, she's not dependent on you and not dependent on anyone else. Our staff, our nurses, and our team is supporting your mother in this time. And it's free of cost. We're not charging anyone anyway. It's the NHS system. And it's her right as a citizen of the UK to get this care. So I don't see the point of you taking her to Switzerland just to kill her. That is very, very merciless to do to a parent. And it's better to let it go like how the natural system of the body goes ahead with it. So you can also tell him, you can say these things. And always in such cases, if you do a lot of, how are you taking it? I can see you're very stressed and you're thinking of other options. But I'm glad you brought this up. Let me update you that it's not possible in the UK. It's this, it's that. If he wants to take his mom to Switzerland, and to be honest, who are we to stop, really? If he is to take her, and that lady can go ahead. If she's not, he is next of kin, and he applies for, discharge my patient or my mother, you go ahead with giving them a discharge against medical advice. So they just go and they can do whatever they want. So you can tell him, I can't stop you from going to Switzerland. However, I can tell you that we're supporting your mother. The system is covering everything. It's free of cost. There's no burden on you at the point regarding your mother, and we're more than happy to take care of her. So these are the sort of things he'll be, okay, doctor, yeah, and all of this. So it would sort of cover it up. And then again, tell him about how it's unlawful, tell him about the good things about end of life care. Now, what is end of life care? It's palliative care. It's subject to the patient's wishes. It's subject to the patient's preferences. It's to provide them with all the support that they need at that point. And you have the right to express your wishes about where you would like to receive end of life care, where you would want to die. You can receive end of life care at home, in care homes, hospice, and hospitals, depending on your needs and preferences. So people who are approaching the end of life are entitled to high quality care where they're being cared of. So these are the points. You read it up and you change it up. Where would you want us to take care of your mother? If you want, we can take care of her at home, or we can keep her there, but we will be providing the care. We'll support your mother, and this is her entitlement as a citizen of the UK, and all of those things. And why are you taking your mother? So just add those things. The other thing I was saying, that you can use metaphors over here, that metaphors as in that I can see that you want your mother to go to Switzerland and you want to end her life, but isn't it that the grass is always greener on the other side, but the grass is green wherever you're standing? So palliative care is very supportive, and there are very high chances that when you take her there, you will take the responsibility of doing this to your mother, and you'll have guilt trip. You're not guilt tripping this person, but you're telling them you'll have guilt all over and forever that you did something that wasn't a nature's decision, that was your decision to do to your mother. So I would highly advise you not to take your mother. However, we're covering her care here. We're taking care of her. She's not in pain. She's not suffering like you're saying. She's not going through anything. And if she were to go through anything, we have the best team to cover it up. We have the best teams to provide her support. So you go along those lines. Don't complicate it too much for yourself. He's not going to stick there and just be really, really harsh and stubborn about different things. He's going to give in if you're nice and sweet and you have a sensible conversation with him. So just keep a low tone, have a lot of sympathy, empathy with him, see his point of view, tell him I understand where you're coming from, and then push forward your own opinion. No, there is no legal obligation against someone to take their parent. You can't stop that person. Legally, you can't.
Dr. Aisha, if the son has the lasting power of attorney,
Yeah.
so in that case, if the patient, son wants to take his mother, so in that case, what should I say? Like, you can do this, or even if our conversation and he is not going to convince.
Sorry, if he's not convinced, so you can tell him.
I mean that if the son has the lasting power of attorney, he can do it or not.
Well, technically, if he shows up at the hospital and he says, I want to take her, and gives no reason, he can. Over here, if you ask him that, so you're telling me that you're going to take your mother to kill her in Switzerland, and if he says, yes, I'm going to do that, then you tell her, well, in that is a very challenging situation, and there'll have to be law involved in this situation, and you might not be allowed to take your mother if that is the reason you're taking her. So you're telling him that he can take her, but if he's providing this as a reason that he's taking her for euthanasia or to kill her, so he will not be allowed to kill another person. So he will understand that.
Okay.
What's
Thank you so
AMA
much.
form? I don't know that. You're welcome. I don't know what's an AMA form.
Dr. Aisha, you mentioned that when the patient refuses some treatment or any sort of thing, and we are going to discharge him, then against medical discharge from something like that you mentioned, discharging against medical advice.
Medical advice, yeah. Yeah, you can as an F2. I do it all the time. You can.
Okay, but I guess isn't it like we are not a safe doctor? Does this convey an image like we are not a safe doctor, that we are offering patient this form?
No, you're not going to offer it. What did I tell Dr. Apsari a moment before you? I told her the same thing, that when he tells you in his words, see, if he says, I'm going to take my mother to Switzerland, can I take her to Switzerland? So you ask him, what is the reason behind you taking your mother to Switzerland? Well, I want to kill her. Well, now that you've said that, I think it will be brought under the notice of police, and it will be brought under the notice of what is it called, law as well, protection law as well, and they'll have to decide whether your mother can go with you or not. So you're just shoving it down on the law, the legal aspects of her discharge then.
Okay.
Am I clear? Because that's what we do here in the UK. Like, if someone by themselves tell you that I am going to harm this person, so then you have to inform the police, and you have to add the legal sources to it as well.
Yes,
Dr.
because
Aisha?
this mom, yes, Dr. Aisha, like because this mom is the UK citizen. That's why the UK law will be applied for her, isn't it?
Yep, definitely.
Dr. Aisha, I have a question. Hello, Dr. Aisha.
Listen.
I have a question. Apart from this, in refusal cases, like if the patient is refusing any treatments or any hospital stay, and he's aware of all the risks and benefits and complications, and we have tried our best by doing ourselves, by involving the seniors, still the patient is refusing, in that case, are we still going to offer him against medical advice discharge form?
Yes, you are going to offer that, and you're going to do a capacity assessment. What's a capacity assessment? It's not that you've told him that, do you know what will happen home? No, you explain it to him. These are the complications that can happen at home. Do you understand what I'm saying? Yes. Can you repeat them for me? Yeah, doctor, this is what I can go through. Oh, well, I'm really sorry that I couldn't help you. Is it possible that you talk to my senior? No, doctor, I don't want to. Well, it's your choice because you're seeing that the case got challenging, right? And you've involved your senior as well, and he still doesn't want to engage with your senior. He wants to go. So that's where you will offer that form that I will be documenting it that you have gone against medical advice today. And that needs to be verbalized against medical
Okay,
advice.
okay,
You're welcome.
okay. Dr. Aisha, I have another question.
Just a minute before you ask another question, I just want to add things here. Those of you who have taken my course and who are due for mocks, for the love of God, listen to the course because I'm correcting the same things that I've fixed in the course for you people. And then you come up with no practice and just having the course and not attending it and not listening to the parts where I've fixed all of these things. And then I'm doing that in the mock. So please, those of you who have attended, who have bought the course, pay attention. Please pay attention and listen. I've done all of these things over there. And when you're in a mock, it's just very challenging for me because I've said all of those things and I'm saying it again to you while you've already paid and you've attended a course. Anyway, okay, Hira, yes, coming back to your question, I had to say that.
Okay, in counseling station, when we already have diagnosis and we are there to tell results to the patient, like of certain things, if it's carcinoma or any thyroid results, in that case, we are so in most of the approaches which we learn nowadays is that first of all we get to know about the history and background knowledge, then we can proceed to tell the results. But if the patient is quite fussy that he wants to know the results earlier, he keeps on asking. So, how can we tackle that situation?
It doesn't happen that way in the exam. There is no fussy patient. There is no single patient who tells you, tell me, doctor, tell me. No, it's not that way. The exam is very basic. The simulators are very calm. They don't have energy at all to argue with you. Trust me, they're just sitting there quiet. So that doesn't happen in the exam, the first thing. The second thing is that you have to ask a little about the symptoms they had and about the severity of the symptoms. So not, you don't have to check with all the symptoms, but you have to assess the severity of the symptoms that they are experiencing with results where you're declaring the results. So that's what's more important. The severity of its impact on their life. That's what you need to assess.
Okay, like if, for example, if we have a patient with ductal carcinoma in situ and patient, we have only diagnosed it by testing and patient is not having any symptoms. In that case, if we don't get the history from patient before getting into the results, so when we break the news of having ductal carcinoma in situ, isn't it that patient history would be biased towards carcinoma and
Patient has
he won't be able
the
to?
least amount of history is tiredness.
Okay.
So you have to check fever, appetite, weight loss, lumps and bumps, lethargy. There will be one of these things she and he, whoever it is, will give you positive. There's always something. There is always something. So look out for it.
Okay, okay. Thank you so much, Dr. Aisha.
Welcome. Dr. Bilal's hand is raised. Is he asking any questions? Has he been waiting patiently to ask questions or is it by a mistake? Okay. Any other questions or are we done?
Dr. Aisha,
Yeah.
can you tell about the prescription writing cases coming these days a bit?
Prescription writing cases are very straightforward. Can we give aspirin with apixaban? Yes, you can give aspirin with apixaban. Have you read it on the BNF? It's contraindicated. No, it's not contraindicated. All the patients with heart failure are on warfarin and aspirin, and you're talking about apixaban, which doesn't even cause a bleeding. So give apixaban and aspirin together. But I think the latest that I heard was lithium with brufen. Please do not prescribe brufen with lithium. It's contraindicated. Stop right there. Give paracetamols for pain as an anti-inflammatory, but do not prescribe brufens. It's a very common mistake for people to do, a very common one, and they damage a lot of things. It has happened on my ward a couple of times, so you have to be very careful with that. What else is coming as prescription? Prescription is very straightforward. All you have to do is open the BNF, and read the BNF. That's it.
Yeah, there is a question. Sorry, there is a question about like coming about MRSA and the vancomycin. We have to find the dose and like we have to write it down. I searched in the BNF, I couldn't find the dose actually. So for how long we have to give the vancomycin?
Let me see. Vancomycin indication and Clostridium
In
difficile infection is given 125 milligram every 6 hours for 10 days, increased if necessary to 500 milligrams every 6 hours for 10 days. That's it.
Sorry, it's MRSA.
Oh, sorry. Yes,
MRSA.
sorry. MRSA. Sorry.
Can you repeat the dose, please?
So, with high risk of MRSA, it's an IV infusion of 1 gram for 1 dose. Perioperative prophylaxis of bacterial endocarditis, IV infusions of community-acquired pneumonia, hospital-acquired, including ventilator-associated. All of these are MSRA sort of infections.
Okay, and they are also giving mupirocin, like nasal.
The fact that vancomycin is given when there is MRSA resistant infections. That's when we give vancomycin. That's why they probably not mentioned methicillin resistant Staph aureus, but it's again it's the same 15 to 20 milligram per kg every 8 to 12 hours. Maximum dose is 2 grams every 12 hours. Adjusted according to plasma concentration. Monitoring duration should be tailored. Let me see it somewhere else as well. MRSA. It's 125 milligram every 6 hours for 10 days.
Okay.
Yep. So whether you have staphylococcal enterocolitis or any of these things, you have to give 0.5 to 2 gram per day in divided doses. That's how it is. And then it's weight guided as well. But I would, like, if I had to prescribe something, I would go with. And what sort of infection is it, by the way? Where is it? Like, is it gut infection, pneumonia? What is it?
I'm not sure about that, but they wanted to give the vancomycin and mupirocin and the paracetamol.
And there was MSRA infection?
Yes.
There will be a little bit more detail to it. Get to know the detail and text me then.
Okay, sure. I will ask.
It's contraindicated with clarithromycin. Oh my God, it is. It's a fact. Okay, anyway, I think we have a minute left. It's ending anyway. Take care, everyone. I'll upload this on YouTube and you can hear it there. And if you have any questions, you can ask other people in the group. That's it. I am done for the day. Bye. Allah Hafiz.